Thank you. And so I thought I would talk about HFpEF because somebody asked me to, and that somebody didn't show up today. So it is what it is. But it's too late to change. And for years, I think heart failure guys tried to avoid and run away and like hate HFpEF just because we don't tend to transplant them. We don't really know what to do with them. But over the last kind of 5 to 10 years, it's become much more of a topic and actually has a true definition now, HFpEF, where in the past it was just this diastolic dysfunction and do you really have heart failure or do you just have diastolic dysfunction, et cetera, et cetera. So the Mayo Clinic really is a group I think that has brought it to the forefront along with Delane Kitzman up at Bowman Gray, who continues to say, I am the person who defined HFpEF, mostly because everybody ignores him now, so he still wants to clarify. But as you can tell here, prevalence of HFpEF really is taking off if you start to look at hospitalizations, where if you look at in red, preserved EF versus in blue or black, whatever you think that is, reduced EF, where really the number of hospitalizations from both is about the same. And you guys see this every day, right? So half of our consults are easily heart failure with preserved EF compared to not. And then, so 2016 is when the first kind of guidelines in terms of a true definition came out from the European Society. And they defined HFpEF on the right as signs and symptoms of heart failure with a normal EF, but then something else. So you either have an elevated BNP, or you have LVH, or diastolic dysfunction on your echo, something else going there besides just a normal EF and shortness of breath, because that could be somebody with COPD. And so putting that extra level of BNP as well as some structural heart disease, they threw in there. They also, of interest, define this HFmrEF, however you want to say that, which is this group with 40 to 49%, mostly to point out the fact that we don't have a clue. None of the meds that we study in low EF patients have ever been really studied well in this kind of group. And so it's a group that you should think about. And again, in academics, it's all about getting your name, papers published, right? So now you can write about HFmrEF and get publications because nobody's ever talked about it before. And so that's my kind of, it's just similar to stages of heart failure, right? So why do we have NYHA class and stages, right? So people can write papers there. So what do I think about it? Normal EF, signs and symptoms of heart failure, and then this, right? So elevated BNP or a big atrium, kind of that Mickey Mouse ears type heart, or diastolic dysfunction, or an elevated wedge, or an elevated EDP is kind of what most people think about that way. And most clinical trials kind of take a definition similar to this when they start to throw people into it. So you really have signs of elevated filling plus a normal EF and symptoms. Now you can have diastolic dysfunction and not have HFpEF. So diastolic dysfunction alone is not enough. You've got to have the signs and symptoms as well. So if you think about who gets it, very busy slide. Couple things to point out here. Again, the Mayo Clinic said it is mostly women, old ladies, normal EF with hypertension, some CAD, some diabetes. Others say it's mostly a disease of hypertension, and you can see that somewhere between 70 and 90% of these case series all have hypertension being in there. Additionally, you see diabetic kind of in the 30 to 50% range there. And then usually it's big people, right? So BMI 32, 30, 37, 33. It's usually kind of big BMIs as well for an average person that rolls in with HFpEF. And so when you start to think about what's going on here, hypertension, BMI, or the things that go on with that, diabetes, how does that screw up the heart? Which may get to really where you start thinking about therapy-wise as well. So my latest kind of thing that I'm ranting about is survival is the same for both of those. But as you heard me say earlier, we never transplant HFpEF patients. I shouldn't say never, almost never transplant HFpEF patients. Now, part of that is probably because they develop it older, and so it's, you know, it's a disease of 70 plus, but we just continue to think about HFpEF differently, even though survival-wise, they really have the exact same curve as those with HFrEF. And we just had this new kind of change in the heart statuses to get a heart. HFpEF really still not included in that whatsoever. So we're looking at some stuff to really kind of look at the under 65 HFpEFers to push that maybe we should be thinking about transplanting some of these people that we don't. Again, with some known comorbidities in there as well. So if you go back to 2011 and say what meds work, if you've got heart failure with reduced EF, in the blue here, everything works, right? So you reduce the risk of death or heart failure hospitalization with beta blockers, ACE inhibitors, blah, 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 blah. If you look at HFpEF, no difference, right? So irbesartan, candesartan, DIG, beta blocker, et cetera, et cetera, et cetera. So the usual meds that we use don't save lives, don't keep people out of the hospital with HFpEF, which gets to the how the heck do you start to treat them. And so if you go to the guidelines, there's not a lot of really good help there, right? So ACC guidelines 2013, control the blood pressure, clearly makes sense. No idea about what meds are best for controlling the blood pressure. Diuretics to reduce symptoms of volume overload. Think about coronary disease and revascularize if appropriate. Manage AFib. And look at level of evidence for all this is C. So this essentially is a bunch of dudes and dudettes sitting around a table saying, oh yeah, let's manage this, right? No data whatsoever to justify anything with level of evidence C. ARBs maybe, but probably not. And then for some reason they went off on nutritional supplements and said don't use them. Again, with not a lot of data to say that they're hazardous, but somebody didn't like nutritional supplements and went off clearly in those meetings. So I think if you think about treating HFpEF, you really need to think about your patient and how that patient is and how you may treat them differently. Above and beyond just taking fluid off, right? Fluid is the number one thing. So I think there's a hypertensive kind of phenotype, a metabolic syndrome, diabetic, BMI high phenotype, a coronary disease phenotype, a right heart failure phenotype who may actually have a normal left-sided filling pressure, or they may be elevated, but predominantly it's right ventricular failure at this time related to end-stage pulmonary hypertension, AFib, valvular, and then rarely you've got kind of the high output heart failure HFpEFers. So patients with renal failure that have 5 or 6 liters of flow going through their fistula can develop high output heart failure. Other things, liver failure, AVMs in the bone, Paget's can cause all this kind of high output heart failure type thing. Fairly rare. I'm going to show you some data that infiltrated may not be quite as rare as we think. Just to point out that coronary disease matters. So the MESA trial is a trial looking at essentially a broad population of America. And they took patients in their 20s and 30s and did a bunch of trash to them and then have followed them now for like 30 years. And one of the things that they did was measure their coronary artery calcium score. And you can see that if you've got normal cores versus a lot of calcium, and these are in patients who did not have coronary disease at baseline. So no symptomatic coronary disease, no diagnosis, just an elevated calcium score. Over the next 5 to 10 years, they start to trend in the wrong direction. So HFpEF plus calcium, some coronary disease, think of them differently. And so I would anti-anginal them and do whatever you can from a coronary disease standpoint in that group of patients. We're now up, there's a study going on that we started when I was at Hopkins, just closing our eyes and biopsying people with HFpEF. And we're getting ready now to write this up. So 90 patients, the vast majority of people have hypertrophy, so stiff, muscle-bound heart, and fibrosis. More have both. Amyloid here though in 14, so that works out to about 18% have amyloid. So think about amyloid, because roughly 1 in 6 of the patients with HFpEF have something else going on. Most of this is senile amyloid, so just old age, bad luck. There's a couple that turned out to be multiple myeloma in here, and then a couple that have the transthyretin mutation, and in their 50s develop amyloid because their liver's cranking it out. So think about amyloid. Right now, there's 1 drug approved for amyloid. There's probably going to be 2 or 3 more by the end of the year, one of which has mortality benefit, even in the seniles. So amyloid, if it's 20% of your patients and you can do something about it, something to think about there. And then there was actually a couple of myocarditis patients, again, in normal run-of-the-mill HFpEF that were there. So last week I promised myself, even if I didn't say it out loud, that I wasn't going to try to do basic science, and then here's more basic science. But if you think about other stuff that's going on with HFpEF, obesity, type 2 diabetes, hypertension, renal insufficiency, all causes systemic inflammation. Just upregulates, you just inflamed, right? A lot of trash going on that way, which will then cause pulmonary hypertension, both skeletal as well as cardiac hypertrophy, sodium retention in the kidney. And you see that with an elevation in reactive oxygen species, you crank up a lot of different things to get myocyte fibrosis, collagen, hypertrophy, et cetera, et cetera, et cetera. So some of these pathways can be blocked. And so in theory, if you start blocking some of this stuff, you might help HFpEF. And that's really where the studies have been going over the last few years, where if you block kind of these upregulated pathways, maybe you can do something and reduce hypertrophy, stiffness, fibrosis, et cetera, et cetera, et cetera. So you see nitrates here can give you more nitric oxide, which is a good thing to have. If you give somebody sildenafil, you can crank up more cyclic GMP, again, on the good pathway, or go on the other side, and there's some PDE9 inhibitors that will actually reduce the bad pathways. So different things to potentially make life good. So has it worked? And this is why I hate basic science, because it doesn't always work, right? So RELAX was a study looking at sildenafil in patients with HFpEF, with the endpoint being improvement in exercise capacity measured by peak VO2. So peak VO2, oxygen consumption. When you're exercising, you're sucking up more oxygen. When you can't do any more, you stop, and you can measure the peak oxygen. So it's a marker of maximal kind of cardiac reserve. And that's actually another topic that I should talk about, is metabolic stress testing one of these days, as I think about it. Anyway, class 2 to class 4, normal EF patients that had a heart failure hospitalization or an increased wedge on the right heart cath or an echo showing diastolic dysfunction plus therapy with a peak VO2 less than predicted and an increase in proBNP. So you get an idea about that patient population, which is really what we're talking about studying. So what do you get with this? Change in peak VO2, both groups, really no difference whatsoever, right? P-value 0.9, no difference between the two groups, and neither one of those groups really changed off of the baseline. So sildenafil does not improve your maximal exercise capacity, and you can make arguments about whether or not that matters. So do you really care if you're taking a drug that improves your maximal exercise capacity if it makes you feel better on a daily basis? You probably don't, right? And so these old geezers and geezerettes, do they really care if they can exercise more as long as they can go to the grocery store? No, they probably don't. So you can argue that it's a bad endpoint, but it's used a lot in kind of phase 2, early phase 3 trials because it's objective and it's reproducible, and you get a feel that it does have some cardiac correlation, that you are improving cardiac performance by it. But patients may not care, and I certainly have a lot of patients that have used sildenafil and feel better on it. It has some pulmonary vasodilatory activity, so it's something to keep in the back of your head, especially if they have high pulmonary pressures, because they're going to feel better even if their peak VO2 does not go up. So what about nitrates? So nitrates in the NEAT-HF trial, again, a lot of theory behind it that may be beneficial. And here they looked at placebo versus Isodil to does it improve daily activity? So that everybody wore an accelerometer, now today it would be a Fitbit. And do they have more steps over the course of a day was essentially what this trial was asking. Again, class 2 to class 4, normal EF, hospital, heart failure hospitalization, or an elevated BNP, or an elevated wedge, or diastolic dysfunction. So again, this kind of broad group of patients, instead of focusing on maybe a group that might benefit more from nitrates. So if you got people with coronary disease, maybe that would be a group that might benefit. So what do you see? Very messy slide, but placebo at different doses versus Isodil at different doses. Essentially at the end of the day, the change from baseline, blah, 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 really didn't change much whatsoever. So another kind of theoretic, great, reality not, potentially because you're studying everybody instead of a specific group that might benefit. So next trial is TOPCAT. TOPCAT was a huge trial, 3,400 patients, Spiro versus placebo, done in North America as well as in kind of the western side of Eastern Europe, if that makes sense. So kind of like the old Soviet Union that are now their own countries. Primary endpoint, death or aborted cardiac arrest or reduction in heart failure hospitalization. And the reason that this trial was done is that Spiro, we think about it from rails, blocks aldosterone. Spiro blocks fibrosis. And a lot of good basic science data, you can reduce LVH. If you biopsy a heart serially, you see less fibrosis over time with spironolactone. So if you've got 90% of these people with a stiff fibrotic heart, getting rid of some of that may allow them to squeeze and relax better, may be a good thing. So as you can see here, primary endpoint of all that, a little bit of a trend in the right direction with spironolactone, but p-values not statistically significant, p of 0.014 here, so didn't quite make it. And if you start to look at just heart failure hospitalization, there, it just made it, right? So the confidence interval went to 0.99. Anything less than 1 means it's a win. So barely made it, but you're not getting real excited about this, where you go from 12% to about 14% at whatever that is, 6 years. So minimal reduction, significant p-value, because you study a gazillion patients, you're going to get significant p-values at the end of the day. So the interesting thing about this trial is that the patients in America look to be very different than the patients in Europe. And so if you look at the patients in America based on their potassium at baseline, in the group, at baseline in America, K is 4.2. If they got Spiro, their K went up to about 4.5, 4.6. If they got placebo, it stayed the same. In Russia and Georgia, a little bit higher at baseline, but both groups, placebo and Spiro, tended to have a bump in K over time. So a little fishy, what's going on, and not as big a bump in K as you might expect. So conversely, if you look at renal function, no change whatsoever in renal function with or without Spiro in Russia and Georgia, compared to in the Americas where you see a bump of about 0.1, 0.15 in creatinine. So some differences between the two groups that way. And of more interest, if you look at primary outcomes, overall, again, this is death, hospitalization, et cetera, in the Americas, significant reduction in the primary outcome compared to Russia, where no difference whatsoever, heart failure hospitalizations as well. But also, look at the differences, right? So these Russian patients are not dying or ending up in the hospital as often as they are in America. So clearly different groups of patients going on here. Now, some people think that the Russians made patients up. Others think they're just a different group of patients, right? So, so for us in the U.S., the ACC, I think, is going to come out and say, give spironolactone, based on the regional differences with this. Now, if your patient is, Nikolai, whatever, then maybe not give Spiro. I had this lady up at Hopkins who was straight from like middle of Russia, couldn't speak a word of English, and so I did not give her Spiro, right? But most of the patients I would think about giving based on this benefit here from that standpoint. So yeah, what's the paper at the end? Possible clinical benefits in patients with HFpEF in the Americas compared to in Russia and Georgia. So other things to think about, I think CardioMEMS can be very helpful. These patients tend to tip fairly quickly, and so if you've got closer monitoring of those guys, you can get a benefit here. Of the Champion trial, 119 patients, so about a quarter of them had an EF over 40. If you look at that group alone, a huge reduction in heart failure hospitalizations compared to the control group there. And there you're starting to really look at big differences, right? 55% versus 20%. So if you want more sleep when you're on call at night, CardioMEMS the way to go, right? Fewer admissions when these buggers come into the hospital. Other things that are coming, so Nisiratide. I don't know why that came into my head. It just came into my head. No to Nisiratide. Nisiratide is not available in this hospital.
Or anywhere. It's not available to order anywhere. It's not a weight method.
Entresto, LCZ 696. There's a big trial going on with this, like 7,000 patients. Probably next fall, a year from now at the AHA, we'll hear the results of that. The nice thing about this drug is it does reduce blood pressure. So knowing that 60-70% of the patients walking in the door have hypertension, in theory this is a good drug to use. Right now it's not approved. You can't give it to your HFpEF patients because their EF's normal, and that's a kicker. And it's expensive, but hopefully that will work and do some of this, right? So if you have more BNP around, less fibrosis, less hypertrophy, et cetera, hopefully it'll work. Time will tell. Other studies that are going on are really with the endothelin receptor antagonists, and we'll see with that. The last thing, and this is a trial that we're going to start up here hopefully sometime next year, if the lawyers get over it, is to actually poke a hole and cause an ASD between the left side and the right side. And the thought behind this is that if you have these high filling pressures on the left side, and you can unload some of this through the ASD and just decongest people chronically that way. In my mind, it might work in the acute setting, but who knows what's going to happen 2-3 years down the road. But for a lot of these people, 2-3 years may be the difference. And so you get this here. So Franny is going to be in the cath lab closing ASDs in some patients and then making ASDs in others, depending on the patient. But small trial that was out there with 44 patients where they actually randomized them to either getting this or having a cath, like a fake cath, where they would poke them in the groin and then just sit around for half an hour and say, okay, we're done. Which, Europe, right? That's not gonna fly in the US, but in Europe, you can do it. And showed that wedge really didn't change in the control group, but in the baseline group, you're starting to see a statistically significant drop in wedge of about 5-6 points. So maybe this is something that works. But this is short kind of follow-up, right? This is 1 month wedges from that standpoint. So quick little summary, in HFpEF, a couple of beta blocker trials that maybe are helpful, but the vast majority of the drugs that we give, the answer is going to be no. Yes, perhaps to Spiro, some small studies that maybe the endothelin receptor antagonist will be there, and then other stuff coming down the road, I think going that way. So what do I think about? Clearly, take the volume off, right? You got to get rid of the fluid with these guys. And then I try to think about the patient and what it is that they do or don't have. So if they've got coronary disease, treat the coronary disease. If they're a bad hypertensive, treat the bad hypertension. Have a small suspicion for coronary disease, because that is something I think you can treat. Diabetes is gonna be most of the month of December, in terms of, treating that, and perhaps some heart failure specific meds, for diabetes. Keep them in sinus, they don't like to be in AFib. Again, I think we're gonna show that 1 out of 6 probably have amyloid. And so keep amyloid in the back of your head, especially if tafamidis gets approved by the FDA, because there's a mortality benefit then to just giving somebody a pill with that. Treat pH, that should be PDE5 inhibitors. Patients like those drugs, they feel better on those. If you've got a reason to do it, think about doing that and go from there. And that's all I got. Thank you very much. Questions?